Before we begin, I would like to go over some logistics for today's meeting. As a reminder, all attendees are muted automatically. If you are having IT issues with the WebEx platform, please send a note in the chat box to host. We will respond to you directly. If you need closed captioning for the event, please press the CC speech bubble icon in the bottom left corner of the application. The closed captioning will pop up for you. You can close it at any time by pressing the CC icon again. We will begin the meeting with opening remarks from Dr. Lee Fleischer, Chief Medical Officer and Director of the Center for Clinical Standards and Quality at CMS. This will be followed with a presentation by Alan White of Apt Associates. After that, we will open the feedback portion of our listening session with pre-registered stakeholders who indicated that they would like to speak. If you registered before close of business on Friday, August 26th, and indicated a desire to speak, we will call on you in order. Please limit your talking points to a maximum of 3 minutes to allow others an opportunity to speak. Keep in mind that a speaking slot is not guaranteed and dependent on our available time today during the meeting. If there is time remaining at the end of the listening session, we will open the floor for additional stakeholders who may have been missed or those who have changed their minds and do want to provide feedback. We will now introduce Dr. Lee Fleischer for his opening remarks. Dr. Lee Fleischer currently serves as the Chief Medical Officer and Director of the Center for Clinical Standards and Quality within the Centers for Medicare and Medicaid Services. In this capacity, he is responsible for executing all national, clinical, quality, and safety standards for healthcare facilities and providers, as well as establishing coverage determinations for items and services that improve health outcomes for Medicare beneficiaries. He is also a professor of medicine and former chair of anesthesiology and critical care at the University of Pennsylvania Perelman School of Medicine. Dr. Fleischer, you have the floor.
Thank you so much, and thank you all for joining us today. In February 2022, the President announced a comprehensive set of reforms aided in improving the safety and quality of care within the nation's nursing homes so that seniors, people with disabilities, and others living in nursing homes receive the safest possible and high-quality care they deserve. One key initiative within the President's strategy is to ensure that every nursing home provides a sufficient number of staff who are adequately trained to provide high-quality care. To achieve this objective, the Centers for Medicare and Medicaid Services intends to propose minimum staffing requirements that nursing homes must meet. It is important to note that CMS is using a multifaceted approach to propose minimum staffing requirements. We initially published a request for information on minimum staffing requirements in April this year, with the fiscal year 2023 Skilled Nursing Facility Prospective Payment System proposed rule. We received over 3,000 comments specific to minimum staffing requirements, which were very valuable. We thank everyone who submitted formal comments. We continue to carefully review all comments, which are being used to inform our research study, design, and CMS's proposed rulemaking on minimum staffing requirements in nursing homes. Our second approach is to conduct a new research study which uses both quantitative data and interviews, that is to say mixed methods, which you will hear more about to assess minimum staffing requirements needed so that the residents receive safe and quality care in Medicare and Medicaid certified homes. This will include some simulations to assess the different options. In addition to reviewing comments received and conducting a new study, CMS will consider feedback from stakeholder listening sessions to inform the proposed rulemaking on minimum staffing requirements in nursing homes, which CMS plans to issue in the spring of 2023. Of course, Once CMS issues its proposal for minimum staffing requirements in spring, 2023, that proposal will go through the notice and comment rulemaking process, providing further opportunities for all interested parties to weigh in. This is an incredibly important body of work that will help to ensure nursing home residents receive the safe and quality care they need. We know that everyone listening to today's call has diverse experience and expertise, and as such, we encourage you to provide candid feedback on several key questions that we have identified and will be discussed momentarily, as well as any evidence that you may have that could be useful in informing our overall approach. Additionally, we hope you will spread the word that CMS is eager to engage with nursing homes to gain firsthand experience, that you all will help us as much as possible. We also want to hear from residents, family members, advocates, and other interested parties so that we can learn as much as possible as part of developing future minimum staffing requirements. We thank you all for joining us today, and we look forward to hearing your valuable input. And with that, I'll turn it back. Thank you so much.
Thank you so much. We will now proceed with a presentation by Alan White with Apt Associates, who will provide an overview of the CMS Nursing Home Staffing Study. Alan White, PhD, is a principal associate with a PhD in economics and 28 years of experience conducting research on nursing home staffing and quality of care. Since 2008, Dr. White has led a team that developed and supports CMS's nursing home 5-star quality rating system. Earlier in his career, he served as the principal investigator for the study of the appropriateness of minimum staffing ratios for nursing homes, a study completed in 2001 that examined the appropriateness of minimum nurse staffing ratios in nursing homes and issues related to implementation of a minimum staffing requirement. Dr. White, the floor is now yours.
All right, thanks, Lauren. Thanks, Dr. Fleischer. So for this part of the listening session, you get to listen to us for a little while. We're going to provide an overview of what we're doing for the staffing study and supporting CMS and implementation of minimum staffing requirements. I'll try to be quick because we want to allow plenty of time to hear from you guys to get your feedback on the questions that we provided in advance of the webinar. You can go to the next slide. All right, so I think most of y'all would agree, largely a consensus that staffing levels, at least at some level, have an impact on quality and patient safety. There's lots of studies going back to the 1990s and probably before that found a relationship between higher staffing and many, many dimensions of improved quality. A lot of studies out there that show that relationship. A lot fewer studies that are focused on identifying specific staffing levels below which residents are at increased risk of quality problems. That is, specific staffing levels where you might want to set a minimum staffing level. So a lot of our research is focused on this bottom bullet here, trying to identify specific staffing levels, below which we see evidence of worse quality, above which we see evidence of better quality, and that might be areas where we might want to consider minimum staffing requirements. Next slide. Just a quick overview of this study. As part of the White House initiative to improve the safety and quality of nursing care, CMS will establish minimum staffing requirements for Medicare and Medicaid certified nursing homes using a multifaceted approach. And this study is a big part, but not the only part of that approach to developing minimum staffing requirements. All right, next slide. Just to give you an overview, the purpose of the study, really we're supporting CMS in the identification of minimum nurse staffing requirements for nursing homes. The minimum staffing requirements will include RNs, LPNs, LVNs, and nurse aides, so just focused on nursing staff. And we're focused on establishing thresholds below which residents are at an increased risk of not receiving the safe and quality care that they deserve. This study is on an accelerated timeline. That is no exaggeration, just for some context. The original CMS staffing study, the one I worked on that wrapped up in 2001, took took 8 or 9 years to complete. It took forever. We're trying to do all this work in a few months, so a very fast timeline because CMS plans to issue proposed rules for the minimum staffing requirement within a year. So this is research that's needed quickly. Last sentence here, this is important context, I think, for folks. Our goal is to build on and not replace previous studies. And I think there's kind of 3 main ways that that shows up in our approach. First, our methodology is similar in a lot of ways to that was used in the 2001 staffing study. The data and analysis that was done for that study are more than 20 years old. So at a minimum, I think we need to update the results using newer data. But also since the 1990s, which is when the data that we used for that study was the period that it covered, there's a lot better data out there. There's newer data. I think we're using newer and better data on the staffing side with payroll-based journal staffing measures versus staffing measures from a handful of states created from Medicaid cost reports, using quality measures that hadn't even been developed back when we did the original CMS staffing studies. I think a lot better quality measures. So we're kind of trying to use the state of the art in terms of the quality and staffing measures that we use in the analysis. The study also includes a lit review that allows us to understand and build on results and methods from other studies that look at the relationships between staffing and quality. And third, kind of building on our work with the CMS 5-star rating system, we're emphasizing staffing measures, quality measures, and measures from health inspection surveys that are used in the CMS 5-star rating system. That allows us to kind of build on the years of research that went into developing those measures, into developing and implementing the 5-star rating system. So we're focused on kind of building on the knowledge base that's out there and not inventing new quality measures or new staffing measures or anything like that for this study. And as a result, the quantitative analyses that I'll talk about in just a few minutes, for the most part being done using data that are publicly available, part of the data that's created as part of the work for Nursing Home Care Compare and the 5-star rating system. So really gives the analyses, I think, a high level of transparency. That is, if any of y'all on the phone wanted to go download the data and try to do what we're doing, at least in theory, you could do it. All the data are out there. Let's go to the next slide. I'm going to talk quickly about each of these main study tasks: a lit review, site visits and related analyses, the quantitative analyses, cost analyses that we're doing, and stakeholder engagement. Let's go to the next slide, which is about the lit review. So we're reviewing the existing literature just to try to understand and summarize other studies that have examined the relationship between staffing levels and different measures of nursing home quality. Lit review is also examining current federal and state staffing requirements and also looking at studies that have looked at the cost associated with nursing home staff and with different types of minimum staffing requirements. So we're focused on identifying and clarifying the relative strengths and weaknesses of the available literature. And as I noted, this is just a way to ensure that our study is grounded in existing knowledge base. There's a lot of studies out there that have looked at issues around nursing home quality and how it relates to staffing. Next slide. So as part of the study, we are conducting a set of site visits. We're going to conduct site visits to a total of 75 nursing homes, doing an initial set of visits to 50 nursing homes, intended to provide information to guide the development of proposed minimum staffing levels. These site visits are just about to begin. I think they start in the next week or two. A second batch of site visits, the second group of 25 nursing homes, that's intended to help validate the initial findings of the study and help support the CMS kind of in developing minimum staffing requirements, because we're sure different issues will be identified as we get into the study. Next slide. So the sample for the site visits was conducted to ensure national representation, as well as a cross-section of nursing homes based on size, ownership type, geographic location, mix of Medicaid and Medicare patients, and 5-star quality ratings. So we have at least one nursing home in each of the 10 CMS regions, and we're planning to conduct site visits in the 15 states that you see shown on the screen here. The number in these states varies, but at least one, and in most cases, more than one for each of these states. All right, you can go to the next slide. So as part of the site visits, we'll be conducting on-site interviews and collecting some survey data. So this is intended to collect qualitative contextual information that we think is important to informing the establishment of minimum staffing requirements. So while we're on site, we'll be conducting interviews with nursing home leadership, direct care staff, residents and their family, all intended to better understand the relationship between nurse staffing levels, staffing mix, and resident outcomes. We're also, for a subset of the nursing homes in the site visits, we'll be collecting some extra data, having direct observation of nursing home staff, focusing on measuring the amount of time that's required to complete specific care tasks. So we anticipate that the sample for this component of the site visits will be higher quality, better staffed nursing homes, so that the care that we observe will be good quality care, because that's what we want to try to measure. How much time does it take to do specific tasks and do them well, provide high quality care. So the data that is collected as part of this direct observation is going to support a simulation model that we plan to build that kind of is another way of trying to understand the minimum amount of nurse staffing time required to provide good quality care. Next slide. So the study also includes a set of quantitative analyses. These analyses use data from a number of different sources, the PBJ data for staffing measures, minimum data set and Medicare claims for quality measures, data also from five-star quality rating system about provider characteristics and outcomes from health inspection surveys. These allow us to measure staffing and allow us to create a variety of different measures of quality of care and resident safety. In terms of the staffing measures that we'll use, we're going to use measures of nursing staff hours per resident day, looking at hours per day for RNs, for LPNs, for nurse aide, for all licensed staff, which is RNs plus LPNs, and for all nursing staff, which is RNs, LPNs, and nurse aides. And we'll be emphasizing acuity adjusted staffing measures in our analyses using the same acuity adjustment method that's used in the five-star rating system. We're using a variety of quality measures, including looking at individual QMs that are part of the five-star rating system, a number of different composite measures, the total QM score, looking at the subset of claims-based measures, looking at the subset of measures for long-stay residents, looking at the subset of residents for short-stay measures, also looking at measures of relative performance on health inspection surveys and citations for specific FTAGs. So the analyses include descriptive analyses of staffing levels, analysis of looking at trends in staffing over time, and also identifying specific factors related to staffing levels. You go to the next slide. And then analyses are being conducted at the nursing home level, using all nursing homes in the country with valid data. And one of the key analyses that we're conducting are multivariate analyses that look at the relationship between our case mix adjusted quality measures and our acuity adjusted staffing measures and other facility characteristics, and just trying to understand exactly what that relationship is between staffing and quality. How does it vary as you look at nursing homes with different levels of staffing? Is that relationship kind of constant? Is it different for low staff nursing homes versus high staff nursing homes? And what can we say about what the data show about staffing levels that are associated with specific staffing levels that are associated with better performance or worse performance on the quality measures that we're looking at? All right, you can go to the next slide. So the study also includes a set of cost analyses, because it's important in considering a minimum staffing requirement to understand what the marginal cost, what the extra costs would be to nursing homes with increasing staffing to be in compliance with any minimum staffing requirement that might be implemented. So for the cost analyses, we're using data from Medicare cost reports, data that has information on average hourly wages paid to RNs, to LPNs, to nurse aides, and also has information on fringe benefit costs. And we're using that information kind of in conjunction with staffing data from PBJ and specific minimum staffing requirements that we might want to test, just to estimate what the costs would be to different nursing homes with being in compliance. And in addition to looking at the overall costs, we want to look at costs for different groups of nursing homes, for example, based on their payer mix, based on their mix of agency staff versus employees, based on their size, urban, rural location, all the different kind of facility characteristics that might be important to consider in understanding the costs. I think these cost analyses are really important because we'll know from the other analyses I was talking about what the benefits of increased staffing are in terms of better quality, better resident outcomes, that sort of thing. Bringing in the cost analysis kind of allows us to balance those benefits or understand how those benefits are balanced against the costs that nursing homes would incur to increase staffing up to whatever level CMS might specify. So we'll be doing these cost analyses, and they'll be an important part of our final report. That's all for that slide. I think it's back to you, Lauren.
Thanks, Alan. As a reminder, we do have some objectives for today's listening session. We do have 5 questions that Alan will read through. Those are the focus of today's listening session. We will be calling folks to speak based on your pre-registration, indicating your desire to speak in the listening session. When we call you by name to speak, you will be able to unmute. Please limit your feedback to 3 minutes total. We will interrupt, unfortunately, at 3 minutes as we're trying to allow for as many people to speak as possible. Please do, if you're in the meeting, you can check the chat. We will be posting the list of upcoming speakers in the chat, so you have a few moments to prepare yourself. And then please stay muted until I verbally call you by name. Time permitting, if there is time at the end of this meeting, remaining stakeholders, either if we have unfortunately missed someone or if you changed your mind and want to give feedback, we will give you directions on how to raise your hands in order to provide feedback during that section. If you joined and you are a member of the press, please indicate that when we call you by name. Unfortunately, this is not the place for press and media questions. And so please use that link that's at the bottom of this slide to instead submit your media inquiries. And Alan, it is back to you to read through those 5 questions.
All right, thanks, Lauren. I will read through them. Question 1. How do we ensure that issues of health equity, healthcare disparities are addressed when establishing minimum nurse staffing levels? Question 2, how do we ensure that both healthcare staff and residents are aware of their nursing home staffing levels and whether or not they're in compliance with minimum staffing requirements? For example, CNA is assigned to a unit or shift and wants to confirm that their assignment meets minimum requirements, i.e. that they aren't assigned too many residents. How can they verify that? Question 3, should minimum staffing requirements be displayed in nursing homes in consumer-friendly ways and be accessible for both visitors and staff? Question 4, when examining the regulatory economic impacts related to establishing minimum staffing requirements, CMS recognizes that RN, LPN, and nurse aide salaries vary by state. How should minimum staffing requirements consider differences in costs for job categories and variations across states? And question 5, 2-part question. What else should CMS consider as part of the staffing study? And what else should CMS consider in establishing minimum staffing requirements that has not been discussed? Lauren, I'll turn it back over to you and we'll start the listening session.
Thanks so much, Alan. I have just a few instructions that I'll go through before we begin with the first group of 5 speakers. It is now time to begin the feedback portion of this listening session, starting with our pre-registered stakeholders. As a reminder, if your name is not called in this section, there will be an opportunity to provide feedback at the end, time permitting. Before it is your turn to provide feedback, you will receive a notification on your screen that you have been promoted to panelist. Once promoted to the panelist role, you will be able to both unmute and turn on your camera, which is optional. We ask that you do not unmute or turn on your camera until your name has been called by me and you have been asked to begin. Speakers connected by telephone should unmute their phones when called to provide comment. Due to time limitations, a speaking slot is not guaranteed, and please keep your feedback to a maximum of 3 minutes to allow others time to speak. Again, members of the press are welcome on today's call, but all press and media questions should be submitted to cms.gov/newsroom/media-inquiries. The expected speaking order for the first 5 stakeholders will be listed in the chat panel. I will also call on each speaker in turn. Again, please stay muted until it is your turn to speak. The first stakeholder is Richard Malott. You may now unmute and give your notes.
Thank you very much. I appreciate that. I'm Richard Malott. I'm the Executive Director of the Long-Term Care Community Coalition, and we applaud the President for taking this initiative and really appreciate the steps that CMS is taking. I just wanted to say that, in making this this promise of reforming nursing homes, the President recognized that too many nursing homes in our country failed to provide the necessary staff to meet residents' needs, both clinically as well as for care with dignity. And nursing homes are, one, they agreed to do that. They're contractually obligated to do that, and they're paid to do that. So a concern I wanted to raise is by looking at how much it would cost nursing homes to comply with the minimum staffing standards, it seems to me that CMS is paving the way for essentially rewarding provider fraud, because if providers now are not providing, sufficient staff to meet the needs of their residents in an appropriate, safe, and dignified manner, they are in violation of the nursing home reform law. Thanks very much.
Thank you so much for your feedback. The next stakeholder is Dion Jimenez. You have been promoted to the panelist group. You may now unmute and give your comments.
Great. Hello, I'm Dion Jimenez, and I'm with the Service Employees International Union in California. And in response to this question, I just wanted to say that it is really important that part of the evaluation looks at staffing levels stratified by race and socioeconomic status, and then by acuity, in order to determine where significant care disparities exist. And with this, then, we can inform policy that will address health equity, and also for policy for facilities to more easily come into compliance with the staffing requirements and improve overall resident care, especially for those that are most vulnerable. Thank you.
Thank you so much for your comments. The next speaker is David Gifford. You may now unmute and give your comment.
Thank you. A couple comments on the questions. It sounds like the issues are going to be on minimum staffing requirements, but like question 2 talks about how do people know about the minimum regulatory standards. Well, if they're a regulatory standard, I think everyone would know about them. But it would be interesting to understand how, given the past studies that Dr. White has described, the relationship of staffing levels and how it changes over time and changes with different acuity. Is there going to be efforts to do a one-shoe-fits-all minimum staffing ratio, or is there some way it takes into consideration that some nursing homes do a lot of high acuity care, some nursing homes do low acuity care, some have a mix of care, and that the relationship of staffing is not perfect. Some high staffing facilities have bad outcomes and some low staffing have good outcomes, and how that's going to be taken into consideration in the study.
Thank you so much for your comments. The next speaker is Janine Ferrari. You may now unmute and give your comment.
Hi there. I am speaking on behalf of my family and my family council members for a nursing home run by the DOH in New York State. And we are wondering, at least I'm wondering, will a DOH run nursing home be part of this survey? And if so, will the ombudsperson and the family members be able to meet with the surveyors beforehand? This is a really crucial set of questions because we have been waiting for our nursing home to be inspected since 2019. Oh, and I should also say our home is run by the DOH, but it's a VA nursing home.
Thank you so much for your comments. The next speaker in order is Toby Edelman. You may now unmute and give your comment.
Thank you. My name is Toby Edelman. I'm an attorney with the Center for Medicare Advocacy in Washington, D.C. Nursing facilities, we know, need enough staff to provide high quality of care to residents. And we also know that most facilities do not have enough staff. This problem is not new. A federal study that Dr. White described by APT more than 20 years ago found that more than 90% of facilities did not have sufficient number of nurses. What's even more shocking is that the nursing home industry admits even today, even now, that 94% of facilities cannot meet that 20-year-old standard. And we know residents need more care now than they did 20 years ago. Research during the pandemic confirmed the decades of research about the importance of staffing. Just one study, a study of Connecticut nursing homes, found that 20 minutes more of registered nurse care per day correlated with 22% fewer cases of COVID-19 and 26% fewer deaths, just 20 minutes a day. The study now underway must identify minimum staffing standards that all facilities must meet and how much additional staff is required as residents' care needs increase. Care will not improve until all facilities have enough well-trained staff. Facilities also need to pay them well, pay them appropriate benefits, and treat them well. My final comment is no more excuses and no more delays. We don't want to have another study 20 years from now. Thank you very much.
Thank you so much for your feedback. The next speaker is Annette Melovitz. Unfortunately, we do not see Annette in this meeting. If you are here but you have joined under a different name, please click the raise hand button to indicate your presence. If you have called in, press the *3 button from your phone to raise your hand. I will pause for a moment to see if Annette is in the meeting. The next speaker in our list is Paulette Sebastian. Unfortunately, I do not see Paulette in the meeting. Again, if you have joined under a different name, please click the raise hand button to indicate your presence. If you have called in, please press *3 from your phone to raise your hand. I will pause for one moment to see if Paulette is in the meeting. The next speaker is Janine Fink-Boyle. You are able to unmute and give your comment.
Thank you. Again, my name is Janine Fink-Boyle, and I am representing Leading Age and our members that include not-for-profit and mission-based nursing homes throughout the country. I just want to have a few comments that go through some of the questions that are listed on here. When looking at the site visits and having time to be in the organizations to review and create a simulation, I think it's really important to make sure that the pandemic has changed the care that is given to residents in interdisciplinary teams. And we want to make sure that the importance of examining all the ways to account for the quality of care is important. We know that here we're looking and talking about nurses, but there are nursing homes throughout the country that have changed some of their models. And I think that's important as Dr. White talked about past studies, and as we're looking towards the future for minimum staffing, that we need to make sure that all the interdisciplinary team is taking into account. The other part that I want to make sure that is brought forward is that the workforce challenges that are throughout the country, and how that will be part of nursing homes as they have different acuity levels, as their staffing levels could vary, and that needs to be taken into account also, as there are workforce challenges. Thank you.
Thank you for your comment. The next speaker is Suzanne Gillespie. Unfortunately, we do not see Suzanne in the meeting. If you are in the meeting but have joined from a different name, please press the raise hand button to indicate your presence. If you've called in, please press *3 from your phone to raise your hand. I will pause for a moment. The last speaker in this first group, or second group, is Kathy Cubitt. You are able to unmute and give your comments.
Hi, thank you. And thank you for this session, and thanks to the Biden administration for dedication to addressing these longstanding issues. As stated, my name is Kathy Cubitt. I'm from the Center for Advocacy for the Rights and Interests of Elders. And a couple of comments. We would recommend that you implement an equity or racial impact analysis of the staffing change, and really any of the changes you're going to be proposing in publication for public comment, to assess the racial impact and create more discussion and focus with the public, how this policy may hurt or help minority populations. Creating a health equity nursing resident advisory committee throughout this process to help, again, identify issues and get feedback. I'm pleased to hear some of the surveys that will occur, but this should really be part of an ongoing process. Other quick points is to really look at the use of agency staff versus nursing home employees. The quality tends to be vastly different in many instances. And I'll wrap up by saying that really the importance of enforcement and compliance, and really doing something about recurring poor performing facilities, especially as they're transferring to new owners that have bad track records, and particularly around staffing. There should be more to address those issues as related to staffing and other quality of care issues. Thank you.
Thank you so much for your comment. Before calling the next group of 5, just a note that we do have a list of pre-registered names for those who have indicated that they are interested in giving comments. Once we have called through everyone in our list of pre-registered names, and time permitting, we will open up for folks to be able to raise their hand and for us to call on them in the order that they are raised. So I do apologize if there are folks who are messaging the host, but for now we are going to go through in the pre-registered list. The next person to speak will be Amy Font. You can now unmute and give your comment. Amy, I do see that you are unmuted, but we cannot hear you. I'm going to call you again at the end of this group of 5, and someone will reach out to you via email with some suggestions. The next speaker is Lori Smetkana. Please unmute and give your comment.
Thank you. Thanks for holding this listening session today and for the opportunity to make a statement. As stated, I'm Lori Smetanka, and I'm with the National Consumer Voice for Quality Long-Term Care. With respect to the staffing study being developed, we recognize the complexity and challenges involved in conducting such a study. But related particularly to the simulation portion of the study, we urge CMS to ensure that it's conducted by researchers who are trained and with experience in conducting these types of studies. Our concern is that the data collected from the simulation portion will look only at what care is currently being provided, rather than also identifying what care is needed or omitted. The methodology must draw out information about what care is lacking, unfinished, or most likely to be left for another day. Importantly, the provision and receipt of quality care includes how it is done, the interaction that occurs between individuals, and how it impacts a resident's quality of life. Thus, the study must also include capturing time required for interaction with residents, incorporating the resident goals and preferences in the way that care is provided. We also urge CMS to rely on quality measures that are not self-reported by nursing homes in the evaluation of the study. It's well known that there are significant disparities between the 5-star staffing and health inspection ratings and the quality measure rating. More than a third of nursing homes with a 5-star quality measure rating have a 1 or 2-star staffing rating, and that can undermine the impact of the study. So thank you for the opportunity to raise these issues today.
Thank you for your comment. The next speaker is Luke Newman. You may now unmute and give your comment.
Thank you, Lauren, and thank you, Dr. White, for your comments at the beginning of this webinar. We appreciate the opportunity to speak. Luke Newman, Vice President for Palm Garden Healthcare. We own and operate 14 post-acute rehabilitation and living centers in the state of Florida. And, a couple of important facts to reference: 87% of nursing home providers are currently facing moderate to high staffing shortages. Indeed, 98% are having trouble hiring nurses and CNAs that we need right now. And given the failure to invest and incentivize nursing infrastructure and to meet the crisis level demand, if there were a minimum staffing requirement as an unfunded mandate today, we would be hard pressed to be able to hire enough nurses, CNAs, or caregivers to be able to meet current demand, let alone a higher demand. And so one of my questions would be, will this study address the potential to include other essential caregivers inside of our beautiful care centers who touch and care for our treasured elders every single day, such as therapists, psychiatric, podiatric specialties, culinary attachés, chaplains? I thank you for your time and for this important work.
Thank you for your comment. The next speaker is Jeremy Skipper. I don't see your name in the attendee list. If you have joined but from a different name, please press the raise hand button to indicate your presence. If you have called in, please press *3 from your phone to raise your hand. I'll wait just a moment. The next speaker is Lori Closet. You may now unmute and give your comment. It looks like Lori may have dropped from the call. If she returns, we will add her to the back of the list. I was also informed that Amy's microphone is not working. She sent in her comment, which is, what if any incentives will be considered to help single or very small homes who may not have the means to raise rates as high as the large corporations with 500 buildings? Rate of pay plays a significant role, especially for nurse aides. Thank you for your comment. We will now move to the next group. The next person is Claire Glover. You may now unmute and give your comment. Claire, I noticed that you were in this meeting twice. If you are having trouble unmuting, someone from the IT group will send you an email shortly. The next speaker is Emily Stockler. Unfortunately, I do not see Emily in the meeting. If you have joined from a different name, please press the raise hand button and we will unmute you. Just a moment for Emily. The next speaker is Lindsay Heckler. Unfortunately, we do not see Lindsay in the meeting. Again, if you have joined under a different name, please press the raise hand button or *3 from your phone to raise your hand. The next speaker is Roxanne Tenna Nelson. Unfortunately, I do not see Roxanne in today's meeting. If you are here but under a different name, please press the raise hand button or *3 from your phone. The next speaker is Scott Gaffney. You may now unmute and give your comment.
Thank you. Hi, everyone. Scott Gaffney from the Greater New York Hospital Association here, in downstate New York. So I think, our, major comments really, to echo some of the earlier comments around inclusion of other types of staff that provide, clinical care as well as therapeutic care to patients and residents at our nursing homes. Specifically for those, that employ physicians, physician extenders, and other, therapy roles. We understand that they have a large impact on the care that's provided to the residents, and we recognize that the nursing categories are essential roles, to the care that's delivered at the nursing homes, but would appreciate CMS recognizing the roles and care that are provided by these, non-nursing titles. In addition, we recognize that there are existing staffing measures that are, adjusted based on patient population, and want to ensure that, CMS recognizes the interplay behind the study as well as the impact on existing measures and how any minimum, potential minimum standard could also interplay with that existing measure that has been used, to date to measure the staffing on a case mix adjusted basis. So that was all of the comments for today. We really appreciate CMS taking the time to host this listening session, and thank you very much for the opportunity to speak.
Thank you so much. The next speaker is Aminsa Luthuli. I don't see you in the meeting, but if you have joined under a different name, you know what? I do see you. I'm going to make you a panelist. And you can now unmute. Give you a moment. You may now unmute and give your comment.
Thank you. My name is Ahimsa Latuli, and I am a senior policy analyst at the Service Employees International Union. SEIU is the largest nursing home worker union in the United States, representing more than 150,000 nursing home workers. I'll briefly be addressing the questions on health equity, awareness of the staffing standard, and varying nurse staff wages across states. Advancing health equity among nursing home residents requires focusing on workforce equity as well as residents' issues. Workforce equity means ensuring that a workforce that is disproportionately composed of women, people of color, and immigrants is treated fairly. This entails ensuring that nursing home workers are compensated adequately for the work they do and have employer-sponsored health insurance and the supports necessary to perform their jobs at a high level. During the height of the COVID-19 pandemic, research showed that nursing home workers who had to work multiple jobs in multiple facilities contributed to increases in the spread of the virus. The driving factor in working multiple jobs is inadequate compensation. When we ensure that nursing home workers are respected in their work, we make it easier for them to address health disparities among residents. The plight of nursing home workers and nursing home residents is inextricably linked, and health disparities among residents will continue to exist until the workers that care for them are treated equitably. On question number 2, we suggest that CMS creates a staff to resident ratio minimum standard, which can accompany an hours per day staffing standard, and facilities should report and display staff to resident ratios on a daily basis for all shifts. This system will help residents and family members easily determine if the facility is in compliance with the minimum staffing standard, since they can simply ask a caregiver, how many residents are you caring for during your shift? And on the question of varying nurse salaries, while it is true that nursing staff salaries vary by state, the median wage for a certified nursing assistant is only $13.56 an hour, according to PHI. It should also be noted that the cost of living varies among states, explaining some of the variation. Additionally, in some instances, nursing home workers have been able to secure higher wages by collectively bargaining through their union. Whether higher wages are the result of collective bargaining, cost of living differences, or supportive employer practices, potential costs related to higher wages should not be used to justify less than safe staffing levels. Minimum staffing levels should be calculated by looking at factors such as resident acuity, the time it takes for workers to assist residents with the activities of daily living, and resident safety. If there are instances where a thorough look into operator finances shows an inability to afford to employ enough workers to satisfy minimum staffing standards, it may be beneficial to scrutinize Medicaid rates or other reasons for the inability of an operator to make payroll. However, nursing staff salaries and wages should not be cited as justification for lowering staffing levels below the minimum safe staffing level. Thanks.
Thank you so much for your comment. The next speaker is Lori Porter. Unfortunately, I do not see Lori in the meeting. If you are here but joined under a different name, or you have called in, please press the raise hand button and *3 from your phone. Just a moment for Lori. The next speaker is Kelly Van Ree. You may now unmute and give your comment.
Hi, thank you. My name is Kelly Van Ree, and I'm the Director of Clinical Services with Leading Age Iowa. And we are a trade association for nonprofit long-term care providers throughout the state of Iowa. My comment is related to the minimum staffing level and the concern that there may not be actually enough people in an eligible workforce to establish these minimum staffing levels, and then how does that affect the nursing homes compliance? In Iowa, we're already seeing nursing homes closing down for various reasons, some of it staffing, some of it financial, and question if CMS has considered what this may do to the nursing homes throughout the country caring for our older adults. Thank you.
Thank you so much for your comment. I've noticed that Kimberly Marsalis sent a note that she is in the media, so thank you so much for that note, and we will move to the next person, who is Michael Wasserman. Michael, I do not see you in the meeting today. If you've joined under a different name, please press the raise hand button or *3 from your phone. Just a moment for Michael. The next speaker is Flor-Delisa McIntyre. If you have joined from a different name, please press the raise hand button or *3 from your phone. The next speaker is Rona Greenspan. We do not see you in the meeting. Again, if you've joined from a different name, please press the raise hand button or *3 from your phone. The next speaker is Kathy Allman. If you are in the meeting, please press the raise hand button or *3 from your phone. Thank you, Kathy. I'm going to move you to panelist. And Kathy, once you are here, you may unmute and give your comment.
Yes, I serve as Vice President of Operations for 6 skilled facilities and 1 assisted living facility. And I, as have already been stated by a couple of the panelists, would like to know what CMS is planning on doing in terms of areas of the country where we are truly struggling hard to find staff. Where I'm located at, it is a daily battle to find staff, to find nurses, to find CNAs. And we also have facilities who are closing down in my area of the country, my state. And it is due to financial and that finally having to pay everything that's been paid to cover using agency staff has caused the facility to go under, and it's just staffing, period. You can't hire enough qualified staff. And I think it's important that whatever CMS determines through this study, that attention is paid to the fact that certain areas of the country may not be doing as well as others when it comes to available staff to pull from in order to meet a minimum staffing level. Thank you.
Thank you so much for your comment. The next speaker is Maureen Amaral. You may now unmute and give your comment. Maureen, I do see that you are muted. I'm going to unmute you. Seems like you're having some technical issues. We will have someone reach out to you. The next speaker is Patricia Budo. You may now unmute and give your comment.
Thank you for the opportunity to provide some input today. I'm the Executive Director of the Pediatric Complex Care Association. We're a national nonprofit organization whose members provide post-acute and long-term care for children with complex medical needs who need 24-hour nursing care. Most of our members are licensed as nursing facilities, so any minimum staffing requirements are going to apply to them. Because of the uniqueness of the needs of the kids that we serve and the services that our members provide, we're requesting that you consider the following. First, because many of our children have severe respiratory compromise, are vent dependent, have tracheostomies, many of our members use respiratory therapists rather than nurses to provide needed respiratory care. And so we're requesting that the hours of care provided by these respiratory therapists be included in the minimum staffing requirements, in addition to RNs, LPNs, and nurse aides. Secondly, all the children that our members serve receive educational services as required by federal law. Significant number of these children are served by the local school district or educational service district at a public school with nursing support provided by the schools. This reduces the number of hours of nursing care that are needed and provided by the facility. And we request that this be taken into consideration as you establish the minimum staffing requirements. The association and its members would be pleased to provide further information if that would be helpful. Thank you.
Thank you for your comment. The next speaker is Sue Milligan. You may now unmute and give your comment. Sue, I do see that you are muted, calling from potentially the app on your phone. If you want to check to see that you are unmuted, please press unmute. Someone will message you shortly. The next speaker is Sarah Dobson. Sarah, you may now unmute and give your comment.
Hello, thank you. This is Sarah Dobson, and I'm with Lutheran Services in America. We are one of the largest nonprofit networks caring for older adults, providing faith-based care to people for over 100 years. Our 200 providers operate 20% of senior residential living beds among the top 200 nonprofit providers in the U.S. Our residents are frail, can't live independently, and require 24/7 care. And have limited resources. Serving them is an essential part of our mission, as is achieving greater health equity and serving unreached communities. But we're concerned about the impact mandatory minimum staffing at SNFs would have on older adults' ability to access care. This issue is already a crisis, with providers reducing occupancy and not meeting existing community needs. Even before COVID and continuing today, providers were in a critical workforce shortage that led to long waiting lists for skilled nursing, older adults languishing in hospitals due to a lack of SNF beds, and vulnerable older adults without quality care options. Unfortunately, the new proposals with no additional funding will exacerbate the current crisis and make it more difficult to hire needed staff. This will lead to fewer older adults able to receive skilled nursing care and more closures in rural areas with already limited healthcare options. We're committed to working with you to expand the long-term workforce, provide training opportunities, and retain workers. We urge you to increase reimbursement rates for nursing home care, since Medicaid has not fully covered costs for years, much less the increased care costs today, with rising workforce and operating costs. This new initiative will only add to unfunded care. The initiatives that provide technical assistance and expand the workforce through DOL collaborations are strong next steps, but without immediate and additional funding, they won't be enough. Other immediate options include easing the path to securing work visas for incoming immigrants and refugees, allowing special visas to fill CNA positions, and instituting a waiver process for immigrants and refugees in the U.S. who want to work in direct care and already have foreign licenses and degrees. Allowing greater flexibility for SNFs to provide on-site training for new hires and existing employees, especially CNAs, would help SNFs grow their own workforce. We strongly urge you to, as you're reviewing and visiting sites, to consider the differences in geography and ability to hire, as well as differing costs and the impact that that has on providers and their ability to meet the minimums. You know, even today, people are not meeting the minimum that was suggested in the earlier survey, and so to put new minimum standards on would only mean that most nursing homes would not be able to be in compliance. So we strongly urge you to reconsider these requirements and just urge you to include the views and experiences of our network of providers and other nonprofit providers with experience in both rural and urban areas, and with a strong mix of high acuity residents. Thank you.
Thank you for your comment. The next speaker is Maria Wagner. If you are here under a different name or have called in, please press the raise hand button or *3 from your phone. The next speaker is Nick Goodwin. I do not see you in the meeting. Please press the raise hand button or *3 from your phone. The next speaker is JJ Rabinowicz. I do not see you in the meeting. Please press the raise hand button or *3 from your phone. The next speaker is Rosemary Simino. You can now unmute.
Rosemary Simino from Golden View Healthcare Center in Meredith, New Hampshire. And I wanted to say a couple of things. I wanted to know or discuss the disparity of Medicaid reimbursement from state to state and how that will play a role in the ability of facilities to pay adequate wages. Also on the concept of acuity and the idea that acuity is fluid and how will the system account for the fluidity of acuity? So like today, I have 3 wound vacs in the building, but that will not probably happen, next week. Also how students and apprenticeship programs and how those staff will be accounted for. And also therapy staff, the therapists provide, activities of daily living and help with e-stim and things with wounds, and I think they should be included. And I was concerned also about regional and local disparities and consideration of the applicant pools in particularly rural areas. I wanted to know if unemployment rates would be considered, and also just the ability of colleges and training programs in regions that have an impact on qualified applicant pools. And also, the last thing was regarding the differences in abilities of nonprofits versus for-profit organizations and standalone independent facilities such as myself versus the ability of chains with different buying power. Thank you.
Thank you for your comment. We do have a few folks in the next group that we do not see in the meeting. So what I'm going to do is read their names just in a row. If you are in the meeting but under a different name, please press the raise hand button. It's at the bottom of your screen, or press *3 from your phone. We do have a number of people who've called in. So the next group of people we do not see in the meeting start with Portia Bachman, Lisa Anatrini, Jay Moskowitz, Carrie Rones, Rebecca Gautier, and Isis Fernandez. If you are here, please press the raise hand button or press *3 from your phone. I will wait just a moment. The next speaker is Gail Ryder. You may now unmute and give your comment. Gail, you are muted. If you can press the unmute button at the bottom of your screen. It's by a little microphone. I'll just give you one moment. The next speaker is Kaylee Lemaster. Kaylee, we don't see you in the meeting. If you want to press the raise hand button or *3 from your phone. The next speaker is Charlotte Nelson. Charlotte, you may unmute and give your comment. Charlotte, I see that you are also muted. If you can press the unmute button at the bottom of your screen. Right, the next speaker is Eric Moffitt. We do not see Eric in the meeting. If you can press the raise hand button or *3 from your phone, we will unmute you. The next speaker is Brett Seekins. You may now unmute and give your comment.
Good afternoon. Thank you for the opportunity to pose a question for consideration. Should CMS institute minimum staffing requirements? Will the program allow for an add-on to states that exceed the threshold set forth by any change? There's many states, as you know, that have minimum staffing requirements today. It may be argued that wage wage indices or community-based statistical areas or other intergovernmental transfers or federal Medicaid allocation percentages may account for differentiation. However, that's simply not the case, as payments versus the actual cost of doing business today, especially today, they're not aligned. They're not aligned at all. Of concern specifically, minimum staffing states have also seen great disparity in Medicaid rates to cover 100% of the cost of implementing these required levels. And this tends to place budgetary limits and constraints to be borne by other payers. Thank you again for your time today and the opportunity to pose this question.
Thank you for your comment. The next speaker is Peter Longillo. Unfortunately, I do not see you in the meeting. If you can press the raise hand button or star 3 from your phone. The next speaker is Amanda Pack. Amanda, you may now unmute and give your comment. And Amanda, I do see that you are muted. If you want to press the unmute button, it is at the bottom of your screen. The next speaker is Stephen Rasso. We actually have 3 that we do not currently see in the meeting, so I will call them in a row. That is Stephen Rasso, Ryan Rossano, and Ben Lau. If you are in the meeting, please press the raise hand button. The next speaker is Carrie Moen. Carrie, you may now unmute and give your comment. Carrie, it does look like you are also muted. If you can press the unmute button at the bottom of your screen. The next speaker is Maria Trotter. Maria, you may now unmute and give your comment. All right, moving to the next, Grace Ellis. Grace, if you are in the meeting, please unmute or press the star 3 button from your phone. Next is Mandy Robinson. Mandy, if you are in the meeting, please press the star 3 button, or sorry, the raise hand button or star 3 from your phone. The next speaker is Lisa Harrison. Lisa, you may now unmute and give your comment.
Hi, my name is Lisa Harrison, and I'm a physical therapist that has a lot of interest in the care of our older adults and post-acute setting. I'm a post-acute manager for the kind of care organization. And, you know, I would encourage in this study to look at the ownership of the facilities and see if there is a difference in the staffing. Because I just, in my role, I see differences. And so, you know, staffing is tough in these days, during the pandemic, there's not enough folks. But I believe that we have a disparity there. So that would be my encouragement. Thank you.
Thank you so much for your comment. The next speaker will be Rear Thompson. Rear, you may now unmute.
Hi, everyone. Thank you. I'm Ryer Thompson with Missouri Slope here in Bismarck, North Dakota. We have 2 nursing facilities and 1 assisted living facility. We've been operating in this community for 55 years. And not that I've been here all 55, but I can tell you in visiting with prior administration before my time that recruitment, retention, staffing has been a challenge for the 30 years prior to the pandemic, and now since the pandemic started has been amplified to unprecedented levels, as we're hearing in this conversation from many, many other people. I'm starting to believe that there is no adequate wage that will attract and retain employees because it's, I believe, a supply problem. I believe it's economics 101, supply and demand. There is not enough supply of people in nursing and certified nursing assistants, environmental services, all the different departments. We could use more help in all departments. And so I guess this is not much of a question, more of a how we're going to do it, but I believe this needs to have more strategic collaboration from other departments of the government outside of CMS in order to develop creative solutions that will increase the supply, specifically of nurses and CNAs into the healthcare industry. I echo what some others have said on the untapped resources with immigration. If we can find ways to unbottle those shortfalls so that we can start to increase and allow people that want to come to America and want to do good, want to work. There are other solutions out there, but just having the president say this is the way we're going to do it and initiate with a stick, we need more collaboration. We need more strategic collaboration across multiple departments of the government to increase supply so that we can have a fighting chance at having this all be very successful, because it should be. Our residents, our tenants deserve the very best. They've built this country and they deserve to have the best care in the world. And we want to offer that. We just need the people that we can hire. Thank you.
Thank you so much for your comment. We have 3 names remaining of our pre-registered group. We don't see them in the meeting, so I'm going to call their names in a row. If you are here and joined by a different name or from the phone, you can press the raise hand button or *3 from your phone. These names are Jody Kelly, David Orn, and Paula Geis. If you are here, please press the raise hand button. I do see a caller who has joined in, so I'm going to make you a panelist. You should be able to unmute now, caller. You may now unmute if you want to give your comment. It looks like that person may have dropped. We now have about 5 minutes left for feedback from folks that were not included in this list of pre-registered speakers. I did see many people who we might have missed. So the next step will be to please press the raise hand button. Again, we probably have time for 1 to 2 more people. I'm calling them in order. I see Allison Herschel, Cindy Frakes, and a person named Eli. I'm going to call you in order. Allison Herschel, I'm going to move you to panelist and you can unmute and give your comment.
Thank you very much. I'm Allison Herschel, the director of the Michigan Elder Justice Initiative. I understand that minimum staffing levels will be based on time task studies and other data and factors, but amplifying on something Lori Smetanka said, I wonder how CMS will take into account the time it takes to have a meaningful interaction with the resident or family member, or be present for a more extended time when a resident is in grave distress, or the time it takes for CNAs, who often know residents best, to participate in care conferences, or the time it takes for staff to engage in training and professional development activities, as well as to serve as a supportive mentor for other staff, or the time for staff to engage in the kind of fulfilling activities and staff appreciation and team building events, peer leadership activities, and other activities that are likely to promote staff's satisfaction and retention. If staff do complete these additional tasks, but they aren't included in the minimum staffing levels, they'll have to spend less than the minimum determined to be required for specific care tasks. And if they don't complete these tasks, they can't provide quality of care and life. So in short, I just say that calculating time for these activities into minimum staffing standards would be the difference between simply ensuring tasks are completed and providing the kind of person-centered quality of care and quality of life that the federal law requires. Thanks.
Thank you so much for your comment. The next speaker is Cindy Frakes. You may now unmute. It looks like Cindy may have been moved back to attendee group. Cindy, if you're there.
I am here, and thank you very much for the opportunity to comment. Appreciate you holding this listening session. I represent the National Institute for CNA Excellence, and our purpose is to help facilitate the recruitment, retention, training, certification of more caregivers to support nursing homes, home health, all across the continuum of care. And one of the things that we see in response to question 5 that we would like for CMS to consider is how to facilitate a more robust way to have CNA qualifications that are consistent across 50 states and easier access for those candidates to use online training programs and to be able to gain licensure more quickly. One problem currently being encountered by CNA candidates is a backlog in availability of testing, for instance. Another would be the availability of classes close to the candidate, and the workforce requires that they be able to access their classes in an area that's convenient for them, and to allow online training in today with today's workforce recruitment and retention is a big plus, and all 50 states do not allow that. Thank you.
Thank you so much for your comments. The next speaker is Eli. Eli, you may unmute.
Good afternoon. Thank you for the opportunity. We are amidst an unprecedented staffing crisis. We're spending approximately 50% more on hourly wages and have yet to see a reimbursement increase. The government is primarily focused on humans that are contributing to care, thereby disincentivizing innovation and finding other ways to help our residents live out meaningful lives. Today, already there are many technologies available, and over the next 5 years, the technologies available will be surprising as to the better outcomes and quality of life that we may be able to provide by leveraging innovation. We are exploring multiple technologies that can augment, not replace, humans. Government agencies with effectively unlimited budgets are finding it difficult to staff and can't find enough staff, health surveyors, IRS agents, etc. We continue to wait far beyond the statute for our surveys. Timing for this initiative is surprising and seems deaf as to our current predicament. This initiative, without contemplation that we must look toward technology, seems to be naive and almost as if we are still in the 90s. Secondly, many providers are facing looming insolvency, and nothing more than suggestions have been made by the Biden administration for chronically underfunded Medicaid payers to change. How will the federal government ensure that there is adequate funding? We'd be happy to staff at any required level, but the expectation to increase an estimated $10 billion in expenses without funding and without available people is puzzling. Thank you again for your time and working toward the betterment of our industry.
Thank you so much for your comments. And thank you to everyone who joined us here to give their comments today. We are nearly out of time, so I'm now going to introduce Adam Richards. Adam Richards is the Acting Deputy Director of the Clinical Standards Group within the Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services. Adam will provide our closing remarks.
Great, thank you, and good afternoon, everyone. I just want to start by thanking each and every one of you for joining today's call. And a special thank you to all of those who actively participated and provided incredibly helpful and constructive feedback. We certainly appreciate everyone's interest in this work and helping to ensure that we at CMS have all of the information necessary to inform the development of minimum staffing standards in nursing homes. And I'll just note that we absolutely hear you. As Dr. Fleischer mentioned earlier, and as we've heard from many of you on the call today, the importance of this work cannot be overstated. That is why we're taking this multifaceted approach and putting a strong emphasis on engaging with all interested parties throughout the process to ensure that we've captured all evidence and various perspectives. While I can confidently say that our efforts are underway, we know that more work remains. Today's call served as a wonderful opportunity to connect with you all and we look forward to continuously engaging as we advance this critically important work. For now, I just want to say thank you again to everyone for participating in today's call, as well as for all the information that you've provided us to date. This undoubtedly will help inform the development of minimum staffing standards as we seek to ensure that residents receive the safe and quality care they deserve. With that said, this concludes our call. Thanks again and take care, everyone.